Yeah, this is a record of a video, and the four PV were isolated, plus SVC also isolated, and the procedure was very smooth and successful. So thank you very much for sharing the case with us. Next, let's go to Sun Memorial Hospital in Guangzhou. By the procedure, is it a live case? The operator is Professor Shuanglun. 谢主任。
好。
Professor Xie, can you hear us? Hi, Professor Jiang. Hello, everyone.
Hello, everyone.
Hello.
Okay. First, Dr. Cao, would you mind to share with everyone about our patient introduction here? So, respected professors, dear operators, can you hear me? Yes, we can hear you loud and clear. Now, please allow me briefly introduce you about our patients. So, 52, female, admitted to the Department of Cardiology, complains its patient have the palpitation for 2 years. Actually, after activity, the patient complained that actually the palpitation is really severe. Besides, the patient after go through ECG, the patient have the really fast AF, and also the patient have hypertension for 6 years. He also used a drug to control the blood pressure, quite good, no specific family diseases. Now you can see no special thing to come to our attention after the physical examination. Now you can see for other parts, electrolyte and also the blood routine, everything is quite normal. So this is about the sinus situations. And now you can see this is about other information. So left atriums 41 nanometers. And also we noticed for the left ventricular wall is more thicker. And also you can see the other parts. The patients also have the abnormal signals here. So the TEE, we have not found some like a thrombus. And so this is a CDPV. You can see the information listed in the pictures, and in the right part, we got 3 branches. So this is about the throw evaluation. The score is 1. However, so after our evaluation, this patient, we decided to give the patient it's more like hypertrophy, so that's why we give the patient anticoagulation. Now, so this is the patient situation. Now we're going to move on to demo. Professor Jiang, now you can continue. Would you mind to let us know what is the protocol, what kind of anesthesia? Well, for this patient, just now you have heard the patient suffered from the AF, and we suspected about HCM, hypertrophic cardiomyopathy. We suspected the HCM. So today, we use the NanoPFA come from the PulseCare, and we focus on the PVI. So later, we are going to for the paraceva, we're going to have some isolation, because we notice sometimes there are a lot of triggers. Trigger local accounts for 10%. So later, we're going to have the isolation. Now we have the nano PV. So especially, anesthesia protocol compared with other like a nanosecond is quite different. It's because it's quite painful. And patients are going to have a convulsion and also have a lot of coughing. So that's why we need to have the general anesthesia. But for the nano PSV, the stimulation to the patients is quite low, so that the pain is not that bad. For this patient, we have used a sedation. Now you can see the coughing from the patient, and also the pain conversion is better, so the patient can have the better tolerance.
excuse me，我打断一下，你这个具体的。
Sorry, I would like to ask you a specific protocol I have not heard yet. So would you mind to let us know? Well, fentanyl together, mizadonin, and also according to patient's weight, it's a 1 vg fentanyl. However, this patient for 60 kg is more like 6 liter. However, a milliliter. But it's more like the catheter ablation for the 6 millimeter. But for the pulse, this is not enough. 6 millimeter, so that's why we double it to 12, or even increase like the triple it. So right now, it's more like 15 mg. Continue. So Mr. Jiang can hear me? Yes, I got it. Okay, so higher than RF. Okay, yes, you got it right. So how you use it for as other drugs? So I would like to know more about heparin. Well, this is more like, abnormal structure catheter. So we got a TA and also some like stroke risk. So that's why ACT during the use it. Before the ablation, we want to make sure at least 300 or above 300 of the heparin. Got it. Thank you. So any other questions? Well, actually, in the last surgery, I almost finished my surgery. So any question? We already we focus on the upper part because the lower part has been complete for the PSV. So we get 3D mapping, but I don't know why you cannot see it. Because after we use the 3D mappings, I think everything is quite visual and clear, but I don't know why you cannot see it in Zoom. So some technical issue, you cannot see the screen for the 3D. Now continue. We focus on the ablation on the right part. Now you can see this is a right upper lung. 3 sides. We already have the 3 sides ablations. Every side, 2 times ablation. So 2 shots in every side. We cover 3 sides. So this is quite different than the nanosecond. You can see this disappear really fast. But whether this is more like irreversible lateral puncture, I'm not so sure. So that's why sometimes we need to have some like doing the together. So why I think you need to have the 3D. Because just now I mentioned about irreversible electrical poration, because in 2D you cannot see clearly whether the ablation is enough. So that's why with the 3D mapping you can see it more visually and everything just straightforward. And then we can increase the successful rate and also to avoid some of the unnecessary risk, especially by involving the irreversible electrical poration. Period. And especially we know that the PulseCare and NanoPSV, they can actually choose.
Switch off some splice. 你可以把它关掉几个电极，关掉几个。
So you can choose to turn it on or turn it off. So it's more like optional. Yes. Especially for certain electrode, if you don't like it, you don't think it's workable, you can choose to turn it off. It's more like selective discharge. Now you can see for this patient, check about the upper right lung. Well, it's quite bigger and thicker. So that's why for the 30 nanometer, we notice the patient still suffer certain problems, especially you can choose the current site, but later I think I'm going to consolidate a little bit to expand it. To expand it, the vestibular. Because if you cannot do it enough, I think the successful rate of the ablation will also be dropped down. So that's why I was consider that perhaps I need to do more like a pulmonary vein atrium's consolidation, especially when the patient has a bigger atrium. You need to expand it, the atriums a little bit. Now you can see this is more like the paddles. So I think it's not enough. So that's why later on, after adjusting the catheter, I'm going to do it one more times. So you can see the paddle shaped catheter. Later, I'm going to expand it, the ablations in the pulmonary vein atriums. So have done it? Okay. So when we do the ablation, sometimes you're going to missing this part, so between these two parts. This is the part I'm showing you. So you can see this is the atriums. After we finish all those modality asked by this, the companies, between these two parts, we're going to have the extra or supplementary ablations. When after the supplementary ablations, according to our observation, the successful rate of the surgery is greatly increased after the supplementary and extra ablation. Now let's do the ablation here.
Professor Shi, can I ask one question?
Okay.
It's very, as I'm watching the patient, it's very clear that there's very little to no muscular stimulation. So that's nice. But my question is, how often, if any time, do you see the coughing reflex that we sometimes see with other microsecond technologies?
是的，在这个纳秒 nano 的 PFA 的这个
So in the nano PSV, well, the coughing reflex is really mild. Almost none. But for the muscle stimulations, yes. Especially in the right upper lung, we observe the stimulations, but not too much. Well, for the coughing, previously when we do the clinical trial of the nanoseconds, one patient, not the general anesthesia, it's a deeper sedation. The patient suffer a lot of pain, coughing so bad. But in the nano PSV, we use the same modality. The patient do not report it with a severe pain or the severe coughing, not like this. Besides, in our center, let's see if you want to do nanoseconds, we go through the general anesthesia with intubation. So to be honest, coughing or the coughing reflex, we don't observe something like this. We give them the drugs, so that's why the coughing reflex is not that bad.
Yeah. Question about durability of the lesions, having durable lesions. And I'm curious if any of the patients that you've treated, have they come back for second procedures because of recurrence or whatever, that you've had the opportunity to look to see whether or not the veins remain isolated? Any experience, or is this too early to ask that question?
Yes, we observe something like this. That in the clinical trial, we are the PI. We participate in clinical trial. And we got 166 cases enrolled. And if I remember clearly, successful surgery 143. Yeah, 143, 80% successful rate. And along the journey, 3 patients come back and mention about the AF recurrence. We have the second times ablations. One patient mentioned about pulmonary vein isolation is not complete. Toothing has been missed. So it's more like lateral between the two parts. The other patient is about atrial flutters, because in the top part, I think it's not done enough. So patient come back with an atrial flutter. Another patient have nothing to do with our proper. He mentioned about the flutter one more time. And but the flutter is actually in the valvular big speculus bispit valves. And with the time passing by, another patient come back. But the patients have not received the surgery in our center. So we notice the vein isolation is enough and complete. However, for the lower part of the right lung, one patient, the staff told me it's not isolated, but I think perhaps when they do the surgery, have not complete or have not done anything for the right part. But anyway, for the nano PFA, I think the pulmonary vein isolation is highly efficient. This is for sure, without any doubt. The other thing I want to see is for the patient who come back due to some recurrence or other issue, and when we do this kind of the ablations, it's just like a one side or two sides missing. You know, this is quite similar to the microseconds. So a lot of reason is for the catheter. You know, for the certain sites, they are not quite close to the certain sites. So, who is next? Who is next?
Yes.
Maybe if I could ask a question.
I have a very similar experience. We have done, just as I said before, I've done 30 cases, and most of them are doing very well without recurrence. Most of them are with paroxysmal atrial fib. We do PV isolation, and some received HVC isolation. And patients doing well, no recurrence. Most of them doing well, and most of them were under conscious sedation with midazolam fentanyl only. But the problem is for posterior wall isolation, because the tip is a little bit long. So it's even with the flower, it's difficult to isolate. You know, like seal to ablate the posterior wall directly. So just is I think the main difference from FlexCarrier.
If I could also ask two very quick questions. Congratulations, beautiful. From what I've seen. The first question with the nanosecond versus the microsecond ablation. Typically with FlexCarrier, for instance, we see complete abolishment of all signals with the first application. Typically, in rare cases, it may not be the case. Any, let's say, learnings from your technology? Do you see some remaining potentials at the different position, or is everything gone? This would be my first question. And the second question, any experience with devices such as interactions with ICD, for instance, or pacemakers? Any initial experience on this?
Okay.
Well, for the experience to share. So first, nano PFA. You know, the charging is really short. So for catheter, they need to be close. Especially during our actual ablation, sometimes the catheter are going to move in. You need to make sure the catheter are going to put in the right position, because discharging is really short. To that way, if the catheter contact is not so good, this are going to bring down the successful rate. Second, consider about the catheter may move. And also for the nano PFA, they have a more demanding for the catheter stability. So that's why during this kind of the ablations, compared with others such as BOGO, the BOGO is also the paddle shape. They are going to do the ablation for 2 shots. Whether it's the atriums and also the other parts, we're going to do the 2 ablation for this 3 sites. 3 sites. So you can see we do more times in the 3 sites and 3 ablations. So which means compared with microseconds as a little bit more. So the microsecond 2 times, this is more 3 times. And in our animal trial, we use whether we use a microseconds or the nanoseconds, in 30 days or 90 days, PSV isolation, and also and the tissue dissections, we notice this result is durable. They are going to last. So compared with the traditional technology, compared with microsecond, the result is comparable. The only thing is they are more demanding for the catheter contact or catheter stability. Another thing I want to mention, in our work, we find something really intriguing. So for the nano PSV, we also notice about the hemolysis. Hemolysis is not that much, so bring down the incidence, the hemolysis. So we do a lot of case. Actually, not so many has reported about abnormal situation and all the increasing for the bilirubin. The other things we mentioned that whether we have done the pacemaker, no, not done it yet. I'm not so sure whether we can do it. So I cannot answer the second question because we have not done it. So that's all. Thank you.
I have one more question. Do you have any experience with additional substrate ablation in the left or right atrium? And once you mentioned that usually general anesthesia is not required for nano PFA. So once you consider to do, for example, a posterior wall ablation, in this case, you still don't need general anesthesia, or you introduce it?
Well,
in our center, we have done other part, not only for pulmonary vein, we do other sides of the ablation. This time, we also use local anesthesia sedation. It's sedation, not general. We don't do general anesthesia, just sedation. And to be honest, I don't really think they're going to affect the result. And to be honest, the ablation site don't have some direct correlation to the anesthesia method you are going to use. So in us, we just use some pain control and also sedation. It's enough of us. And for the site, we do a lot. It's more like we do more part in the parakiva. And we use the paddles to do the isolation for parakiva. It's fast and safer. And also for the posterior wall, we tried it before, and you can still do it. But to be honest, for the patient, if you use this way to do those posterior wall, and so from the longer period, we don't have data, so that's why I cannot give you the answer now, because you use a paddle shape, whether they are going to cause for some or whether they are going to cause some other issues. But to be honest, I think Catheter, you can use it to do it. I totally agree with Dr. Jiang. So because we have not tried for the roof line or the left atrial roof line, and but to be honest, because the catheter is long, so that's why in the posterior part, perhaps not like buccal, you can do it more smoothly. So consider about it's more like a PulseCare. Please be careful. Don't cause any a cardiac or the cardiomyopathy damage. But I think for the company in the future, they are going to adjust it and optimize equipment quite similar to the MaviPulse.
Good job. I have one question. I have want to know, is Nano-PFA effective in patients with persistent atrial fibrillation? Do you have some experience or only paroxysmal?
So you mean the persistent AF, or which part? Do you mind to give us more information?
Ayan 的意思是，谢主任，他说是有没有在持续房颤里面的经
So
验
the persistent AF, persistent AF. Okay, so in this part, well, right now, for the persistent AF, the experience not that much. For the persistent AF, for the duration, let's say just within 1 year, or the patient atrium is not that big, the atrium size is not that crazy, we just only do the PPI, and we'll also use a similar catheter. But if the patient atrium is larger, almost like a 50, nanometer, the patient suffer from disease for so long, and also get some like other diseases, coronary diseases, and other diseases, and also diabetes. I don't really think to use a PPI only is not quite that successful. So I strongly suggest a linear ablation. But to be honest, I prefer the pedal, like whether it's a PulseCare or the Nano PFA or the FirePulse PFA. Well, the linear ablation, I'm not a big fan of it. I'm never a big fan. I prefer like point ablation, so that we are going to cause like only limited damage to the atriums. This is my experience.
Yes, and Dr. Ayan, I agree with Dr. Xie. In persistent HFib, which duration of AF less than 1 year, if a strategy is only PVI alone, maybe plus HVC isolation, I think is okay. But for other substrate ablation, like linear ablation, this nano PFA is, I think, has some limitation. It's a very difficult to achieve the endpoint.
Can I also ask, I appreciate that most of the ablation is being done for the veins, and that makes a lot of sense. And I appreciate the difficulty of trying to do posterior wall ablation, but I'm curious if there's been any experience with ablation near any of the coronary arteries, whether it's the CTI or the mitral isthmus. And specifically, I'm curious to know what, if any, effect you've seen in terms of coronary spasm on the coronary arteries. Is there any information, or you have not ablated near the coronary arteries with this technology?
OK， 我觉得这是个非常好的问题。那这个
Well, million-dollar question. 2 points I can share with you. To be honest, as long as you are going to do coronary artery, or at least close to it, you get the electric field, there will be some spasm. At least you have the spasm potential. So that's why Nanosecond PFA, I think there will be similar phenomena like this. You need to be aware of it, prepare for it. But for the nanoseconds or the microseconds, whether there will be different spasma, to be honest, I'm not so sure. We have an animal trial right now. I think I'm going to answer with your question with some data future, such as let's see for the different pulse engine. Let's say one is a nanosecond, the other is a nanosecond. In different experiment control, compared with a control group, we can see whether there will be different level of the spasma. I will come back with animal trial and data. And besides, you can also check more about like their impact on the fields. And besides, we are going to have the more studies. So such as the field intensity. We also try to study more for the field intensity. The other things about we also focus on the tricuspid valve. So something you may not observe immediately, but I want to see that there are some progress for the pulmonary because we have not done a lot of the surgery on the tricuspid valve.
Excellent. That'll be very important information. I'm glad you're doing this.
是，谢谢。看看蒋老师有没有其他一些问题？
Professor Jiang, any other question? Well, no more. Oh, so thank you so much, Professor Xie.
我差不多做完了，我可能有一
Almost finished. Perhaps I need to check extra site to see whether it's necessary to have the supplementary or extra ablation. Now let's proceed.